Good morning, students. Today's topic of our lecture is urgent gynecology. Urgent gynecology, or another name of today's topic, is acute abdomen. What is acute abdomen? Is a symptom complex shown by the expressed painful syndrome in an abdominal cavity, presence of vegetative disturbances, increase of temperature, and tachycardia. What pathologies include in today's topic and in the phenomena of an acute abdomen? It's some inflammatory diseases of internal genital organs such as endometritis, endomyometritis, salpingopharitis, pelviperitonitis. Another group of diseases, it's benign tumors of genitals. It's more correctly said complications of some benign tumors, such as perforation of ovarian cyst or rupture of ovarian cyst, its torsion of the leg of ovarian cyst, its necrosis or torsion of myomatous node. Third group, it's ovarian apoplexy. Fourth group, it's ectopic pregnancy. Fifth group, it's traumatic disturbances of internal genital organs such as perforation of the uterus during abortion or diagnostic curettage of an uterus. And sixth group, it's malignant tumors of internal genital organs. About some diseases we will discuss today. We start from fourth group, it's ectopic pregnancy. What is ectopic pregnancy? It's pregnancy in which the fertilized egg implantation occurred outside the uterine cavity. I pay attention not only in the uterus, outside the uterine cavity, because if happen implantation into the cervix, it will ectopic pregnancy, but cervix is part of the uterus. Classification of ectopic pregnancy. It may be abdominal pregnancy, tubal pregnancy, maybe pregnancy in the fallopian tube, rupture of the fallopian tube due to pregnancy, and tube abortion. Pregnancy in the fallopian tube, another name we say that it's progressive ectopic pregnancy, when pregnancy develops into the fallopian tube but without rupture of this tube and without tubal abortion. Only development of ectopic pregnancy. Another location, it's ovarian pregnancy and other form of ectopic pregnancy. It's such as cervical, combined, in the corner of the uterus if present some abnormalities of the uterus, intraligamental, it's one type of abdominal pregnancy, in the mesentery of the uterus, and ectopic pregnancy unspecified. Over the course, it's progressive, such as I said before, progressive or interrupted. It's tubal abortion or rupture of fallopian tube. And sometimes it's missed abortion, when pregnancy happened but not developed. Causes of ectopic pregnancy. It's inflammatory process in appendages of the uterus when absent normal function of the uterus, or maybe obturation of the fallopian tubes. Sexual infertility when undeveloped, when decreased level of sexual hormones and absent normal development of female genital organs. Is disturbance of contractile activity of the uterine tubes, endocrine disturbances, some tumors in the fallopian tubes or maybe in the uterus, in the cervix, in different types in different genital organs. It's hyperactivity of trophoblast, scar commissural changes, in pelvic operation previously different due to the internal reproductive organs, pelvic peritonitis or abortion, endometriosis, long-term use of intrauterine contraceptive devices, and assisted reproductive technologies. At this picture you can see anatomy of fallopian tubes, and the fallopian tube is about 10 centimeters in long. The diameter of the lumen varies from 1 millimeter in the interstitial portion to about 5 millimeter at the fimbria part. And of course must be normal function in the every parts of fallopian tubes. In fallopian tubes present two layers of muscles, an inner circular and outer longitudinal, and peristaltic movements are strong during and after ovulation. The mucosa consists of a single layer of ciliated and secretory cells resting on a thin basement membrane. Owing to inflammatory diseases in the lumen of a tube, there are adhesions, strangulations, and broken peristaltic movements. Quite often in women who were treated concerning infertility, partial permeability of tubes is restored, but peristaltics is broken. That is the reason of occurrence fallopian pregnancy. At presence of sexual infertility, the uterine tubes are long, twisted, their peristaltic is defective. Through such tube, the ovum has not time to penetrate into the put term in a cavity of the uterus. Pathogenesis. Implantation of fetal ovum occurs where it appears by that moment when trophoblast begins the fermentative activity, enzyme activity. Corian villi take root in the wall of a tube, thus its muscular layer is hypertrophies. The uterine tube accepts the fusiform for 5 weeks. Pregnancy is aborted. Seldom it proceeds over 8 weeks. Now we said about tubal pregnancy. If the wall of fetal cistern inverted into the lumen of a tube is ruptured, fetal ovum starts to perish. It is exfoliated from walls of a tube, and owing to peristaltics is gradually thrown out in the abdominal cavity through the ampulla end. There is a fallopian abortion, which is accompanied by bleeding various intensity. Thus, blood through the tube acts into the abdominal cavity and through the uterus outside as blood discharge. At fallopian abortion is pregnancy developing in an ampulla, part of a tube is more often aborted, and it is often accompanied by not plentiful bleeding. Now we will discuss about clinical manifestation of tubal pregnancy. If we said about progressive ectopic pregnancy, I must say that signs of pregnancy will be same such as normal uterine pregnancy. Some signs will be same, such as dilated menstruation, such as breast enlargement, change of the taste, the smell, and other sensational characteristics of normal uterine pregnancy. Early signs of toxemia, sometimes it happens nausea, vomiting. During gynecological examination, we can find cyanosis of the mucous membrane of the vagina and cervix. Uterine size is smaller than the expected term of pregnancy. It's not correspond with normal gestational age. And near uterus unilateral enlargement and tenderness of uterine appendages is at the left or right side, depend where this progressive ectopic pregnancy present. When we said about interrupted tubal pregnancy, clinical signs will be seen, such as in case progressive ectopic pregnancy, but plus some additional signs. This occurs mainly from the narrow isthmus before 8 weeks of pregnancy or later from the interstitial portion of the tube. The symptomatology of the tube rupture is typical. Suddenly there is a pain in the lower abdomen, such as constant or cramp-like pain in a groin, irradiates to the rectum, perineum, sacrum. Also in a shoulder and scapula, it's phrenica symptom caused by irritation of the diaphragmatic nerve. But in case rupture of fallopian tubes, present internal bleeding, and of course additional sign, it will be general signs such as weakness, dizziness, cold sweat, decrease of arterial pressure, loss of consciousness, weak rapid pulse, nausea, vomiting, pallor of integuments and mucous membranes, cyanosis of nasolabial triangle. Hemorrhage is likely to be severe. You see that present some signs of hemorrhagic shock, and intensity of some clinical signs will depend from volume of blood loss. The abdomen is more painful at palpation from that side where has taken place rupture of a tube. Schottky-Blumberg symptom is weakly positive. It's peritoneal symptom. Positive Kuhlenkampf symptom, it's signs of peritoneal irritation in the absence of local muscle tension in the abdominal cavity. The body temperature is normal. At percussion, loss of resonance in slow places is defined. In process of increased hemorrhage, severe hemorrhagic shock develops and collapse. Maybe flatulence, diarrhea single. During vaginal examination, insignificant bloody discharge are found out. The uterus is slightly increased, softened and more mobile than usually, a swimming uterus. In the field of appendages can be palpated tumor-like formation. The posterior fornix is impressed or protruded. Acute morbidity of the posterior fornix of vagina is marked, it's Douglas cry, and pain during displacement of the cervix, it's Promptom symptom. Promptom symptom sometimes we use for differential diagnosis between rupture of ectopic pregnancy, tubal pregnancy, and between appendicitis. If we displace cervix and present pain, it's interrupted ectopic pregnancy. If during displace cervix, if after displace of the cervix absent pain, we think about appendicitis, acute appendicitis. Following signs can help in diagnosis of ectopic pregnancy. Now you can see different signs, such as Lafan signs, consecutive shift of pain feelings, at first of suprabrachial part, then shoulder, then pain spreads into back part, scapulars and understernum. Another sign, when present abdominal edge presence, that is followed by its irradiation into shoulder and scapulars on tubal rupture site. Ehlers signs. Another sign, its urging to urination appears during tubal rupture moment. Kuhlenkampf sign, such as I said before, it's intensive pain during percussion of anterior abdominal wall. Landau's sign, intensive pain during speculum or fingers inserting into vagina. Golden sign, uterine cervix pallor. Bold symptom, acute pain during an attempt to displace uterine cervix. Goodell sign, soft consistence of cervix. I must say that same sign present if uterine pregnancy. When happens soft consistency and cervix and sometimes isthmus. Prompt of sign, woman feels acute pain during an attempt to displace uterus up by inserted into vagina and rectum fingers. I explained it before. At appendicitis examination per rectum causes pain is retrauterine pouch. And the Goffman sign, it's uterine displacement into contrary from alterated tubal site. At long blood presence in abdominal cavity, its partial resorption take place and transformated bilirubin deposits in skin cells. That's why there appear such signs, such as Goffstetter sign, its presence of blue, green or blue-black coloring of skin in navel region. I must say it's not specific signs of tubal abortion. It's a sign or some signs of internal hemorrhage. Another sign, it's yellow skin coloring of palms and soles, especially in fingers area. If happen tubal abortion, again, in case tubal abortion may be some same clinical signs. Again, will be same signs of progressive ectopic pregnancy. At abortion of pregnancy as fallopian abortion, attacks of pain in the bottom of abdomen, bloody discharge take place. Frequently there are short-term syncopes. It is palpated slightly increased soft uterus and tumor-like formation in the region of appendages. Painful at palpation, limited in mobility. In some cases, impression of the lateral and the posterior fornix of vagina is defined. Morbidity at displacement of the cervix and palpation of the posterior fornix of vagina more poorly are expressed than at rupture of a tube. Investigations. Qualitative and quantitative test of human chorionic gonadotropin must be performed at all reproductive age women who present with pain, bleeding or collapse. In a normal pregnancy, the level of beta-HCG doubles every 48-72 hours until it reaches 10,000 till 20,000 of milli-international units per milliliter. In ectopic pregnancy, beta-HCG levels usually increase less. It's increase, but not double every 48-72 hours. Means serum beta-HCG level are lower in ectopic pregnancy than in healthy pregnancy, normal uterine pregnancy. No single serum beta-HCG level is diagnostic of an ectopic pregnancy. Serial serum beta-HCG levels are necessary to differentiate between normal and abnormal pregnancies and to monitor resolution of ectopic pregnancy once therapy has been initiated. Of course, gold standard for diagnostic of ectopic pregnancy, different type of ectopic pregnancy, is ultrasound examination. In case ectopic pregnancy, no ovum in the uterus, the embryo visualization outside the uterine cavity, revealing the formation of heterogeneous structure in the projection of the fallopian tubes, a significant amount of free fluid in Douglas space. Of course, fluid in Douglas pouch present if happen rupture of fallopian tube or tubal abortion, if present blood in abdominal cavity. Couldacentesis. This means passing a needle through the posterior fornix into the Douglas pouch. Intraperitoneal blood does not readily clot, and if such blood is obtained, it is an indication for surgical treatment performed in the absence of ultrasound. Laparoscopic investigation and diagnostic curettage of walls of the uterus, no elements of ovum and the presence of decidual tissue, is performed in the absence of ultrasound. Tubal pregnancy. What treatment? Immediate hospitalization. Each woman with suspicion on ectopic pregnancy should be hospitalized and must stay in stationary until clinical confirmation or refuse of suspicion on ectopic pregnancy. Surgical operation. It's laparotomy or laparoscopy. And what types of operation? It's salpingectomy or plastic of a tube. It's such as tubotomy or salpingostomy. Laparotomy has usually been required where there is extensive intraperitoneal bleeding. Laparotomy we use when impossible use laparoscopy. After surgery, with preservation of the tube for the prevention of persistent strophoblast requires a careful toilet of abdomen by 2 to 3 liters of physiological solution and single dose of methotrexate at a dose 75 100 mg intramuscular in the second day after surgery, if it's necessary. Infusion therapy depends on the stage of hemorrhagic shock. Infusion or maybe transfusion therapy depends what severity of blood loss. But sometimes, in case tubal ectopic pregnancy, we can use conservative treatment. I want to pay you attention that we use it only in case progressive ectopic pregnancy. If present rupture of fallopian tubes or tubal abortion, In this situation, we don't use conservative treatment. Indication for use of methotrexate in case of ectopic pregnancy. It's elevated levels of beta subunit of HCG in serum after organ-preserving surgery on the fallopian tube, which is made in the progressive ectopic pregnancy. Or in case stabilized or increased level of beta subunit of HCG in serum within 12 or 24 hours after separate diagnostic curettage or vacuum aspiration, if the size of the ovum in the uterus does not exceed 3.5 centimeter. Determination by transvaginal ultrasound probe of gestational sac with diameter less than 3.5 centimeter in the uterus in case of beta subunit of HCG of 1,500 international units per liter shows absence of the ovum in the uterus. Methotrexate is the standard medical treatment for unwrapped ectopic pregnancy. The optimal candidates for methotrexate treatment of ectopic pregnancy are hemodynamically stable, willing and able to comply with post-treatment follow-up, have a human chorionic gonadotropin beta subunit, concentration less than 5,000 milli-international units by milliliter, ectopic pregnancy fully visualized on ultrasound, embryo size under 3 cm, tubal serosa intact, no rupture, no fetal heart activity, normal lab testing, and no active bleeding. The dose of methotrexate used to treat ectopic pregnancy is 5 mg per 1 square meter or 1 mg per kg, followed by checking the level of HCG. Methotrexate can be given systemically. Usually it's intravenously or intramuscularly, or by direct local injection into the ectopic pregnancy sac transvaginally or laparoscopically, and intramuscular administration is most common, and it's present in guidelines and recommendations. If the beta subunit of HCG in serum decreased less than 15% of the 8th day, methotrexate re-enter the same dose. If the beta subunit of HCG in serum increased more than 15%, the patient watched weekly, determining the level of beta subunit of HCG as long as this level is not less than 10 international units per liter. You can see different protocols which we use in our practice, and when we check level of HCG in dynamic. When we use single dose. But again, same dose, it's 1 mg per kg. And maybe multiple dose, it's when we use methotrexate and leucovorin. I must say that it's all cytostatics. We use it for kill chorion, for kill embryon. And you see that if we use single dose, success rate is 88.1%. In case multiple dose, success rate increase, it's 92.7%. How we use monitoring after conservative treatment? Inadequate beta-HCG response requires intervention. Methotrexate may be repeat dosed in protocol 1, indicated for inadequate beta-HCG decrease between days 4-7. Surgical intervention is failed protocol, indicated if beta-HCG increasing despite 2 or more doses of methotrexate or signs of hemodynamic instability. Follow quantitative beta-HCG. First week, draw beta-HCG days 4 and 7. Anticipate 25% beta-HCG decrease between days 1 and 7. Anticipate 15% of beta-HCG decrease between days 4 and 7. If inadequate decrease, repeat methotrexate protocol above. Subsequent weeks, draw beta-HCG weekly. Anticipate drop to 5 micro international unit by milliliter by 3-4 weeks. Serum progesterone may also be followed. Anticipate drop to 1.5 mg per milliliter by 2-3 weeks. Now we will discuss about another pathology. No, it's not another pathology, it's same, it's ectopic pregnancy, but another location of ectopic pregnancy, it's ovarian pregnancy. Developed in case of fertilization in the cavity of the follicle. The frequency is 0.5 till 1% of all ectopic pregnancies. Risk factor use of intrauterine contraceptive devices. Clinical signs are the same as in tubal pregnancy. In case of disturbed ovarian pregnancy, the clinical hemorrhagic shock is possible. Diagnosis: ultrasound, fallopian tube on the side of the stricken ovum is the projection of the ovary. Fertilized egg to the uterus connected to their connection ovary. Among membranes, visualized ovarian tissue and positive qualitative reaction to HCG. What treatment in case ovarian ectopic pregnancy? Only surgical. Only surgical removal of the ovum and the resection of the ovary. In case of massive ovarian lesions and severe bleeding, we use ovariectomy. Cervical pregnancy, when the fertilization happens into the cervix, into the cervical canal. At this situation, diagnostic more easy because we can visualize cervix during speculum examination. During speculum examination, we can see cyanotic cervix. During bimanual examination, uterus with cervix as hourglass because enlarged size of the cervix. Again, gold standard is ultrasonography. The absence of fertilized egg in the uterus, endometrial hyperheterogeneity, deciduous tissue, uterus as hourglass, extension of the cervical canal, the fertilized egg into the cervical canal, placental tissue in the cervical canal, and closed internal uterine os. And treatment of this situation Usually it's surgical. It's hysterectomy, but today present new modern technologies when we use embolization of vessels, and sometimes we can treat this pathology without hysterectomy. It's not in all clinics possible, only when present angiosurgery department. You can see cervical pregnancy, enlargement size of the cervix, and closed internal os. You can see empty uterine cavity, present only decidua in the endometrium, but embryon located into the cervix. Embryon into the cervix. It's uterus, it's endometrium. You can see that increased thickness of endometrium because present decidua. Next type of ectopic pregnancy is abdominal pregnancy. It may be primary or secondary abdominal pregnancy. There are primary, it's implantation of a fertilized egg in the abdomen, and secondary formed when a fertilization happened into the tubes, but this egg comes into the abdominal pregnancy after into the abdominal cavity after the tubal abortion. Maternal mortality in abdominal pregnancies 7 to 8 times higher than in the tube and 90 times higher than in the uterus. Diagnostics of abdominal pregnancy, it's more difficult than in case tubal, ovarian or cervical pregnancies. Clinical manifestation in the first and early second trimester are not very different from the symptoms of normal pregnancy or tubal pregnancy. At a later date, a pregnant complain of pain during fetal movements, feeling stir in the epigastric region or sudden cessation of fetal movements. Of course, if second trimester of pregnancy. In early term of pregnancy, this clinical signs absent. In physical investigation, the easily palpable soft parts of the fetus and uterus alone small size. Uterus again not correspond with gestational age. Maybe enlargement of the uterus because present decidua and muscular transformation, but uterus less than gestational age. Abdominal pregnancy is diagnosed in the absence of uterine contraction after oxytocin. For diagnosis are used ultrasound, X-ray, computer tomography and MRI if it's necessary. If we can't diagnose it before, during ultrasound. Again, you can see, for example, this example, that happen fertilization only outer surface of the uterus, happen implantation into the uterus, but implantation can happen in every places, in the region of liver, in the region of intestine, in the region of mesenterium, in different place of abdominal cavity. And of course, clinical signs and duration of this ectopic pregnancy will depend from the place of implantation. Treatment. Usually it's surgical treatment. We remove this pregnancy, ectopic pregnancy. During the surgical treatment of isolated and tie up vessels that supply blood to the placenta and possibly remove it. If this is not possible due to heavy bleeding, placenta need to backfill. Tampons are removed in 24-48 hours. In case of placenta after surgery in the abdominal cavity, her condition is assessed by ultrasound and determination of beta subunit of HCG. In these cases, there is a very high risk of intestinal obstruction, fistulas, and sepsis. The use of methotrexate is contraindicated since it is accompanied by serious complications, especially sepsis. The cause of sepsis is massive necrosis of the placenta. Another rare types of ectopic pregnancy when pregnancy located between ligaments. If tubal pregnancy, chorion villi don't grow into the abdominal cavity, but interside of broad ligament of the uterus, separating it, embryo comes into space between leaves of ligamentum latum or broad ligament of the uterus and continues to develop between them. Embryo protected by leaves of the broad ligament can develop to late tomes or even to full tome. However, more frequently interruption of such pregnancy in 2-3 month tome take place. At its interrupting, a big hematoma accumulates, and if the leaves of the broad ligament are routine in the result of chorion villi, penetrating bleeding into abdominal cavity can appear. At this picture you can see ectopic pregnancy in additional cornea, in rudimentary uterine cone. At this situation, of course, only surgical treatment when we remove this rudimentary cone. Next pathology, which include in today urgent gynecology, it's apoplexy of ovaries. What is apoplexy of ovaries? It is suddenly come hemorrhage which combine by disturbances of integrity of ovarian tissue and bleeding in the abdominal cavity. Among all reasons of intra-abdominal bleedings, of 0.5 till 2.5% falls on apoplexy of ovaries. The bleeding from ovary precedes formation of a hematoma, which causes sharp pains owing to increasing of intra-ovarian pressure. Then follows rupture of ovarian tissue that result in bleedings even at a small perforation in an ovary. It's such as rupture of ovaries. Rupture of ovary arises owing to stagnant hyperemia, varicosity, or sclerosing of vessels, and also sclerosis changes in stroma. Change of vessels and tissues of ovary grows out pathological process, more often inflammations of appendages of the uterus. Provoking factors of ovary apoplexy can be a trauma, physical pressure, the rough sexual intercourse, trauma of the abdomen, operative intervention, mechanical pressing of the vessels by pelvis tumor. Ovarian apoplexy can come in various phases of a menstrual cycle, but it is more often observed during the period of ovulation. Usually it's 14th day if duration of cycle 28 days. And in a stage of vascularization of the corpus luteum. It is more often observed in women of 20-25 years old. There is more often a rupture of the right ovary. Clinical picture. It is associated two forms of ovarian apoplexy depending on expressiveness of this or that clinical symptomatology. It's painful and anemic form. And sometimes we said about third form, it's mixed form when present signs and pain and anemic signs. Ovarian apoplexy usually sharply begins with occurrence of sudden, sometimes very strong pains in the bottom of the abdomen, with primary localization of the side of injured ovary. At examination, the presence of peritoneal wall, positive Schottky-Blumberg symptom is marked. At percussion of the abdomen, the free liquid in the abdomen cavity can be defined. At the plentiful bleedings, there is a phrenicus symptom and the phenomena of a collapse. Quite often, an attack of pain is accompanied by nausea and vomiting. Bimanual research gives a possibility to set gynecological nature of the disease. Pain of vaginal fornixes is present. Displacement of cervix causes strong pain. Uterus is of normal size and pain is determined in ovaries region from the one side. Injured ovary of softish consistence, sharply painful, enlarged. Valves of a vagina are sharply painful. It's another name, it's Douglas cry. It's painful during palpation of posterior fornix of vagina. Palpation of the uterus is complicated because of acute morbidity at presence of significant hemorrhage in the peritoneal cavity and irritation of the peritoneum. Sometimes we said about swimming uterus when we can very easily displace this uterus. And I pay you attention that Douglas cry and swimming uterus, they are present in not in case of one pathology. It may be in case rupture of fallopian tubes, in case ectopic pregnancy, or in case internal hemorrhage due to ovarian apoplexy. And they are combined with irritation of peritoneum. The differential diagnosis with fallopian pregnancy, with pregnancy in fallopian tubes, apoplexy comes suddenly, frequently in the middle of a menstrual cycle. There are no signs of pregnancy. The external bleeding is not present usually. Biological reaction to pregnancy are negative. Additionally, we must differentiate ovarian apoplexy with appendicitis. As for differential diagnostics with acute appendicitis, one must remember that in appendicitis more frequently pain initiate at the epigastric region. There are nausea and vomiting and no signs of internal bleeding. At abdominal examination, muscular defusal and positive Schottky-Blumberg symptom are observed. At appendicitis, the temperature is increased. In blood are leukocytes. We have leukocytosis. Of course, in case ectopic pregnancy and in case ovarian apoplexy, level of leukocytes will be normal. Treatment. If the bleeding is insignificant, absent signs of hemorrhagic shock, It is possible to be limited by conservative action. It's rest, it's cold compress on the bottom of the abdomen and whole hemostatics at the painful form. If present only pain, if absent signs of internal hemorrhage, sometimes at this situation conservative treatment if enough. For hemostatic therapy, usually we use tranexamic acid until 3 grams per day if we use it orally. At significant bleeding operation, it's laparotomy or laparoscopy. We use in internal genital organs, we use resection of ovary or ovarian raphe when we use suture on the ovary, or coagulation of ovary is shown. Depend what severe hemorrhage, what condition of ovaries, what technical possibilities, qualification of doctor and other. Another pathology is torsion of leg of ovarian tumor. Quick motions, pregnancy, labor, stormy bowel peristaltics can use torsion. Torsion or twisted of peduncle or leg of ovarian tumor. In the result of torsion, trophies of tumor tissue disturb, degenerative changes and necrosis with wall rupture in it. You can see this torsion at these parts. At this part you can see necrosis of tissues. You can see that dark color. It is divided on a degree on partial and complete or full torsion. On time it's acute and gradual. It is allocated anatomic and surgical leg or peduncle of a tumor. The anatomic peduncle includes a proper ligament of the ovary, suspensory ligament of the ovary, vessels and nerves which are taking place in these ligaments. Arteria avarica, ramus avaricus of arteria uterina, and mesoovarium. The surgical leg includes above the listed anatomic formations and also parts of bodies or other anatomic formations involved in torsion. It's uterine tube, intestine, omentum, and other organs or parts of organ which include into the torsion. If it's happened, we use usually surgical treatment. It's removal of a tumor together with the leg. The clip is imposed below a place of torsion, irrespective of the fact that anatomic formation have gotten torsion. The leg of a tumor cannot be untwisted. I pay you attention. In avoidance of thrombohemorrhagic and infection complication, because if we untwist this tumor, all toxins which present because happen necrosis of ovary, all toxins can pass into general blood supply and provoke toxic shock, and we can't untwist this formation. Another pathology which happen which we include in the topic of urgent gynecology, it's ovarian cyst rupture. You can see it's on these pictures, and this picture, you can see fluid into the abdominal cavity. what I want to say about ovarian cyst rupture. Of course, it's not rare situation. Sometimes our patients then know about cysts, and if present some cysts in the ovary, we are not recommended for patient different physical exercises, run, jump, sexual active sexual intercourses, because it can provoke rupture. For diagnosis, we use ultrasound examination when we can see some formation in the ovary and fluid into the abdominal cavity. Of course, during palpation, we can diagnose some pathology in the region of the ovary, some formation, and palpation will be very painful. And main clinical sign, main complaint, of course, it's pain in the region of the ovary. Usually it's sharp pain. And sometimes for differential diagnosis, what type of fluid present into the abdominal cavity, sometimes we use kuldacentesis. Kuldacentesis in its puncture of Douglas pouch through the posterior fornix of vagina. Sometimes we take some fluid and we can see we can differentiate it's blood, or maybe it's some fluid from ovarian cyst, or maybe pus if present purulent, some purulent formation. Another pathology, it's necrosis of myomatous node. Necrosis of subserous myomatous node is most frequently occurred. It is possible a disturbance of blood circulation in a tumor in the postnatal and post-abortive period, at presence of a long leg, torsion of leg or peduncle of myomatous node. Of course, leg possible only if subserous or submucous myoma, but sometimes happen necrosis of intramural myomatous nodes if happen occlusion of vessels. Of course, it's more rare situation, but it's possible too. Clinical picture in case necrosis of myomatous node. It's acute pains in the bottom of the abdomen, pressure of muscles of an anterior peritoneal wall, increase of temperature and leukocytosis. You see that present signs of intoxication, and signs of intoxication present because happen necrosis and intoxication, and these toxins can pass into the blood supply, and clinically it will be pain and plus signs of intoxication and inflammation changes in the laboratory results. At vaginal examination is defined presence of myomatous nodes in the uterus, one of which is sharply pain at palpation. Further to aseptic necrosis is almost always joined the infection penetrating into a node by hematogenic or lymphogenic way, and in some cases from intestine, more often from an appendix. And treatment at this situation, of course, it's operative treatment. We make amputation or hysterectomy. Conservative myomectomy can be made as exception in young childless women in condition of antibacterial therapy. And of course, our treatment will depend from location of this node, from size of this node, from age of patient and reproductive plans. And you can see maybe different leg, different peduncle. If more thinner, this peduncle more easy can happen torsion of this leg. You can see it's uterus, it's subserous myoma. If happen torsion in this place, of course, such as result, we can see necrosis of myomatous node. You can see again that present torsion of leg and happen necrosis of the tumor. Next, uterine perforation. Of course, we must remember about this complication. Uterine perforation may be during curettage, during hysteroscopy, during abortion, during when we put intrauterine device. And of course, our tactic will depend from situation, why it's happened, by what instrument it's happened. Of course, if it's a thin instrument, if no severe hemorrhage, no pain, sometimes in rare cases we use conservative treatment, analgesics plus antibiotic therapy, and of course if it's thin perforation without any complication, without trauma of some another organs. But if it's happened by big instrument, for example, by during curettage, or if present trauma of some another organs, of course, at this situation, only surgical treatment. We must visualize organs near the uterus, and we are use suturing of the uterus. Usually it's laparoscopic operation, but we must suturing for prevent hemorrhage, for prevent infection. Another pathology is Pia-Salping's rupture. Pia-Salping's it's purulent formation into the region of the fallopian tube. If present some inflammation when happen occlusion of the fallopian tube and pus accumulate into the fallopian tubes. In an abscess rupture takes place spontaneously or in the result of physical trauma. Clinical picture: before abscess perforation, there is always patient's health change to the worse. Pain reinforces, temperature rises, peritoneum irritation symptoms are intensifying. Just after rupture, their appearance an acute pain which has a cutting character through the abdomen, collapse, nausea, vomiting, stomach is strained and strongly painful. General patient's state becomes worse. The face features sharpen. Breathing becomes frequent and superficial. It's signs of intoxication again. In the result of bowels paresis, abdomen becomes flatulent, peristalsis disappears, and meteorism develops. Diagnosis: during stomach percussion, one can find blunting of sound in lateral departments because of exudate presence in abdominal cavity. During bimanual examination, uterus and ovaries palpation is impossible because of acute pain and tension of front of abdominal wall and vaginal fornixes bulging. Pelvic peritonitis may develop in the result of pia salpinx rupture. Specification of the diagnosis can be made by means of ultrasonic research and Coulthard synthesis, such as I said before, when we use puncture of posterior fornix, puncture of Douglas pouch. If we diagnose pia salpinx, what treatment? It's operative cure with ablating of alterated ovaries and following drainage of abdominal cavity is necessary because it's purulent situation for prevent pelvic peritonitis. Laparotomy should be made by lower middle incision because of this access gives a possibility to make a revision of abdominal cavity organs and its wide drainage. And if it is necessary, peritoneal dialysis. Operative intervention is inevitable anyways. However, before operation, it is necessary to make detoxification and start antibiotics. Of course, not only surgical. Of course, we must use desintoxication therapy, it's infusion therapy with antibiotics. We start from antibiotics of broad spectrum, not less than 5 days, but duration and dose and type of antibiotics depend from severity of process and severity of patient's condition. You can see it's uterus, it's purulent formation, it's pia salpinx into the region of fallopian tubes and ovary. And you can see rupture of formation, you can see pus from this formation. And same again, you can see it's uterus, it's purulent formation in the region of appendages, in the region of fallopian tubes and ovaries and ovary. And last pathology which I want to explain today in the topic of urgent gynecology, it's pelvic peritonitis. More complete, more full information you will study at the cycle in the topic of inflammatory diseases of female genital organs, but I want to pay your attention that this topic, of course, it's acute abdomen topic. Pelvic peritonitis can be partial if it's happened near salpinx or near ovaries, in parametrium, or diffuse extending on parietal and visceral peritoneum of a small pelvis. The term pelvic peritonitis is concerned to an inflammation of all peritoneum of a small pelvis. Pathogens of disease are usually the pathogenic and conditional pathogenic microflora causing inflammatory disease of the bottom departments of a pelvis. Pelvic peritonitis is usually developed again owing to penetration of microorganisms on uterine tube and at inflammation of fallopian tube, and this canaliculate way is primary for gonococci and little bit less often of pyogenic microbes. The primary focus of infection can be not only in the uterine tubes, but also in ovaries, uterus, fat of small pelvis, an appendix, and other bodies from which infection acts by lymphogenic or hematogenic way. Pelvic peritonitis can arise at suppuration of post-uterine hematomas, cyst or cystoma, torsion of a lac of cyst with the subsequent contamination, perforation of pia salpinx. It is allocated serofibrinosis and purulent pelviperitonitis. The acute stage of serofibrinosis process is characterized by disturbances of microcirculation, hyperemia, edema of peritoneum, occurrence of serous exudate to which fibrin is added, albumins and segmenta nuclear leukocytes. There are dystrophic changes in the peritoneum. On a measure of calm down of inflammatory process, there is a restriction of infectious process by limits of a small pelvis that promoted by formation of commissars between parietal peritoneum of a small pelvis, uterus, appendages, bigamentum, loops of intestine. And deposition of plenty of fibrin and rather fast delimitation of a process, typically for purulent pelviperitonitis. What is clinical picture of pelviperitonitis? Of course, it's high body temperature, increase of pulse, bad state of health, strong pain in the bottom of the abdomen, chilling, fever until 40 degrees and more, swelling of the abdomen, pressure of muscles of an anterior peritoneal wall, positive Schottky-Bloomberg symptom, positive peritoneal symptoms. Peristaltics of intestines is weaker than must be, tongue is dry, cover, nausea, vomiting, maybe increase level of erythrocyte sedimentation rate. It's again signs of inflammation. Increased level of leukocytes, shift of leukocytic formulas to the left. During gynecological examination, in the first days only rigidity and mobility of the posterior vault of the vagina are marked. The next days in this area exudates is revealed. Palpation of the uterus is sharply painful. It is possible precisely to palpate because of sharp morbidity of the anterior peritoneal wall. And treatment. It is based on principles of complex therapy of acute inflammatory process. Not depend. It's gynecological problem or maybe surgery, inflammatory process. Same principles. Full rest, cold on the bottom department of the abdomen, and of course antibacterial therapy. It's wide spectrum of antibacterial therapy in a combination with metronidazole for treatment of anaerobic infection, infusion and desintoxicational therapy, intravenous drop infusion of crystalloids or colloids. If necessary, we use transfusion of fresh frozen plasma or albuminous preparation. Of course, it's individually. We choose and decide question about infusion or transfusion therapy depend from the severity of pathology. But main, of course, it's surgical treatment. It is appointed antihistaminic preparation and correction of acidic alkaline condition, often adequate infusion therapy. But I repeat again, if present pelviperitonitis, we must use surgical treatment. For restoration of intestine peristaltics, of course, we use some medication for increase these peristaltics. In case of occurrence of abscess in retrauterine space, make a puncture of the posterior fornixes for evacuation of pus with the subsequent infusion of antibiotics in area of a small pelvis. For the best evacuation, make drainage through the posterior wall of the vagina. At correct treatment later, 1-2 days, the general condition is improved. Intensity of clinical displays is gradually reduced. Hemic parameters are improved. At absence of effect from spent therapy, it is necessary surgical treatment, which volume depends on a stage of disease. Today I finished my lecture. Thank you for your attention. Take care of yourself. Goodbye, students.